Let's go ahead and get started. So in today's video, we're going to be discussing the different types of necrosis and how it's different from apoptosis. This topic forms the foundation of pathology. Understanding these processes is essential because they appear in clinical scenarios like myocardial infarction, stroke, and infections, which you'll encounter both in exams and also while you're in practice. By the end of the video, you'll have a firm understanding in concepts of cellular death, necrosis versus apoptosis, coagulative, liquefactive, caseous, fibrinoid, and gangrenous necrosis, key terms that differentiate each, clinical relevance, and also USMLE practice questions at the end, not only to test your knowledge, but more importantly, solidify your knowledge for the long term. Also, be sure to check out thehealingpowerofnature.com and also our Patreon for the best study materials available on the market. To start, let's go ahead into some basic principles of cell death, some etymology that's very important that you're familiar with. First would be pycnosis. Pycnosis comes from the word pycnos, which means thick or dense, describing nuclear condensation. We also have karyorexis, from the Greek karyon, which means nut or nucleus, and rexis, meaning bursting. This refers to the fragmentation of the nucleus. We also have karyolysis, from karyo, meaning nucleus, and lysis, meaning dissolution, referring to nuclear dissolution. These terms reflect nuclear destruction, which is a hallmark of cell death. Understanding these terms is essential. So key concepts: loss of the nucleus. The defining morphologic hallmark of cell death is the progressive destruction of the nucleus, which occurs in 3 distinct steps. First, like we talked about, pycnosis, the nucleus shrinks and chromatin condenses, resembling a tightly packaged ball of string. Karyorexis, the shrunken nucleus fragments into smaller pieces, akin to a shattering glass ornament. Karyolysis, the fragments dissolve into the cytoplasm like sugar dissolving in water. A good mnemonic is just PKK. When the loss of the nucleus, PKK. Pycnosis, karyorexis, karyolysis. The mechanisms of cellular death. How do cells die? It happens in 2 distinct ways. First is necrosis. Whenever you hear the word necrosis, I want you to think of the murdering of cells. This is because necrosis is uncontrolled cell death caused by external injury. It is always pathologic, never physiologic, and triggered by insults such as ischemia, toxins, trauma, or infection. It always results in inflammation because the cell membrane ruptures, spilling contents into the extracellular space. Versus apoptosis. Apoptosis is the suicide of the cell. Apoptosis is a highly regulated, energy-dependent process of programmed cell death. Can be physiologic, like during embryogenesis or immune cell selection, or pathologic, like DNA damage or misfolded proteins. No inflammation without spilling intracellular contents. It's mediated by capsases, which orchestrate the cell's orderly breakdown. It's initiated via 2 major pathways. You have the intrinsic or the mitochondrial pathway, which is triggered by cellular stress like DNA damage or lack of survival signals, and you have the extrinsic pathway, the death receptor pathway, which is triggered by external signals binding to death receptors like the Fas-Fas ligand interaction. A good analogy: think of necrosis as a building being destroyed in a chaotic disaster, leaving debris everywhere and causing a public disturbance. Versus apoptosis is a building being carefully deconstructed by workers. I went ahead and generated this chart for you. I recommend taking a picture of this and keeping it close. It refers to apoptosis versus necrosis. Let's go through this quickly. Apoptosis, it's controlled, energy dependent. It's often physiologic, but sometimes pathologic. There's no inflammation, and capsaces are the activation via apoptotic bodies. Versus necrosis. Necrosis is uncontrolled energy independent. It's always pathologic. It causes inflammation. Remember, necrosis causes inflammation and also cell swelling and membrane rupture. So first, coagulative necrosis. Coagulative necrosis occurs when necrotic tissue remains firm and denatured proteins coagulate, preserving the structure of cells and tissues despite the loss of cellular nuclei. Key features: morphology. Tissue shape is preserved but nuclei are absent. The cause is primarily due to ischemia, loss of blood supply, except for in the brain, which undergoes liquefactive necrosis. Pathogenesis. Ischemia causes lack of ATP, leading to protein denaturation, firm tissue, and hypoxic injury, cell death. Causes are ischemia in solid organs, except for the brain, commonly seen in the heart, kidney, and spleen. Some pathology that you'll see: Wedge-shaped infarcts due to arterial occlusions with the wedge pointing to the site of vessel blockage. You'll also have color infarcts. For example, you'll have a pale infarct, which organs with a single blood supply like the heart, kidney, and the spleen. And red infarcts, organs with dual blood supply like the lungs, intestines, testes, or in reperfusion injury where blood re-enters damaged tissues. When it comes to coagulative necrosis, think CCK, coagulative clotting proteins keep structure. Some high-yield examples that you'll see in USMLE and also in clinic would be myocardial infarction or heart attack. You'll see pale firm tissue. Another one is kidney infarction, which you'll see wedge-shaped pale necrosis. Testicular torsion is another high-yield example with red infarction due to venous congestion and reperfusion. When it comes to pale infarcts and red infarcts, think of a pale infarct as grilled chicken. It's firm, cooked proteins but lifeless tissue, whereas a red infarct is picturing a bruised apple, damaged tissue with blood leakage in. Next, liquefactive necrosis. Liquefactive necrosis is necrotic tissue is completely digested by hydrolytic enzymes, resulting in a liquid pus-like mass. Some key features that you'll see is the tissue is soft, liquefied, and may form cystic spaces or abscesses. It's dominated by neutrophils, which release enzymes that digest the tissues. Some causes would be ischemic injury to the brain and bacterial or fungal infections. Pathology, microscopic appearance, tissue debris surrounded by inflammatory cells, which are primarily neutrophils. Gross appearance, soft, liquefied areas that may appear cystic or pus-filled. A pneumonic liquid brain or pus. The brain infarct's ischemic stroke leads to liquefaction due to enzymatic digestion. Pus, bacterial or fungal infections create pus-filled abscesses. Some high-yield examples, a cerebral infarct or an ischemic stroke. Causes are hypoxia or ischemia to the brain. Another high-yield example is a liver abscess caused by bacterial infections like E. coli or Staph aureus. And another example would be a lung abscess caused by aspiration pneumonia or Staph aureus infection. An analogy, think of liquefactive necrosis like melting ice cream, initially solid but enzymatic actions break it down into liquid. Some key words you can look out for are soft, liquefactive tissue, neutrophilic infiltrates, pus-filled abscesses, or ischemia in the brain. Next, caseous necrosis. The definition, caseous necrosis is a combination of coagulative and liquefactive necrosis. It's characterized by soft, cheese-like appearance of necrotic tissue. Some key features that you'll see. The morphology, necrotic tissue appears yellow-white, crumbly, and cheesy under gross examination. The histology is central necrosis surrounded by macrophages, multinucleated giant cells, and lymphocytes, or granuloma formation. The most common causes you'll see are tuberculosis, TB. This is the most common cause worldwide. You will see this not only in clinic, but more importantly on test. It's caused by Mycobacterium tuberculosis, which triggers a granulomatous immune response. Additionally, fungal infections like Histoplasma capsulatum. Common in immunocompromised patients, these fungi can also induce granulomas with caseous necrosis. Some pathology, the causes like we talked about, TB and fungal infections, but with a granuloma formation. What's a granuloma? Granuloma is central necrotic area surrounded by epithelial macrophages, multinucleated giant cells, and lymphocytes. Necrotic area represents the breakdown of infected cells and organisms. Some common stains you'll see for TB, you'll see the acid-fast bacilli, so the Ziehl-Neelsen stain, or for fungi, periodic acid shift, PAS, or silver stain. Pneumonic, think of caseous, cheese-like necrosis. Automatically think TB, and fungi loves cheese. To look out for is a patient with a cough and chest pain after desert travel. An analogy, think of crumbly cheese or dried mashed potatoes, soft, yellow, white, and grainy in texture. Some USMLE testing clues, look for granulomas, central necrosis, cheese-like appearance, acid-fast bacilli, and fungal stains. Common scenarios would be patients with chronic cough, weight loss, night sweats, that would be pulmonary TB or caseous necrosis. Patients with fever and exposure to caves/bats. Histoplasmosis. Next, fibrinoid necrosis. The definition, necrosis in blood vessels. Definition, necrosis in blood vessel walls caused by severe injury leading to the deposition of fibrin and immune complexes. Look at the name, fibrinoid. So from just the name, we can recognize that there's fibrin in the response. It appears as bright pink amorphous material on histology. Some pathogenesis, how it occurs. Vascular damage leads to endothelial injury, fibrin leaks and immune complexes deposition, and weak and inflamed vessel walls. Histology is eosinophilic or pink fibrinoid material within the wall of blood vessels. Common causes immune-mediated vasculitis, severe hypertension, and preeclampsia/eclampsia. What is preeclampsia and eclampsia? This is where fibrinoid necrosis occurs in placental vessels, contributing to poor placental perfusion. Pathology. There's weakened and leaky vessel walls, inflamed and fibrin deposition create structural instability, and the gross appearance is not visible. Histologic examination is required. Mnemonic, think fibrinoid, fibrin plus vessel injury. Fibrin leakage into damaged vessel walls, vessel injury, often immune-mediated or due to severe hypertension. Some high-yield examples for USMLE Step 1, polyarteritis nodosa, PAN, preeclampsia or eclampsia, malignant hypertension, or Wegener's granulomatosis. An analogy you can think of cracked water pipes patched with plaster or fibrin. The vessel is temporarily reinforced, but the damage remains fragile and prone to rupture. Some key USMLE words: bright pink fibrinoid material on histology, vessel wall necrosis, immune-mediated complex deposition, or malignant hypertension. Lastly, gangrenous necrosis. The definition is gangrenous necrosis refers to mummified tissue caused by severe ischemia. However, it's often seen in limbs or extremities, even in the GI as well. There's two forms. There's dry gangrenous, which is coagulative necrosis. Tissue becomes dry, black, and shriveled. And there's wet gangrene. Superimposed bacterial infection leads to liquefactive necrosis, resulting in swollen, foul-smelling tissue. Some key features. Dry gangrenous results from ischemic injury without infection. Tissue is black, dry, and mummified. Wet gangrene occurs when bacterial superinfection is added to ischemic tissue. Tissue becomes swollen, mushy, foul-smelling due to liquefactive necrosis. Common causes: peripheral vascular disease, PVD, seen in diabetes, for example, severe frostbite, a bowel infarction where ischemic necrosis of intestine, commonly presenting as wet gangrene, and gas gangrene is a special subtype of wet gangrene where gas bubbles in tissue causing crepitus. Pathology, with dry gangrene limited to ischemic coagulative necrosis, commonly affects distal extremities like the toes in diabetics. Wet gangrene, superimposed bacterial infection, causes liquefactive necrosis, which is rapid progression with systemic toxicity like fever or sepsis. Remember gas gangrene, which is caused by Clostridium perfringens infection after trauma or surgery. Key clues: gas bubbles in necrotic tissue, crepitus with rapid tissue destruction. Analogy, think of dry gangrene as like beef jerky, dried out, shriveled, and mummified, where wet gangrene is like a rotting banana, soft, mushy, and infected. Some USMLE keywords: dry, black, mummified tissue, that's going to be dry gangrene. Foul smelling, swollen necrotic tissue. Wet gangrene. Gas bubbles in necrotic tissue, gas gangrene caused by Clostridium perfringens. So let's go ahead and jump into some USMLE practice questions. Like I'll always tell you, begin with the last sentence, then read your answer choices, then read the entire question. So I'll go ahead and give you a few minutes and then we'll review this question. So if you chose D, dry gangrene, that is correct. That's because this patient's presentation of mummified toes with black discoloration and no signs of infection is classic for dry gangrene. So let's go on to the next question. I'll go ahead and give you a few minutes and then we'll come back and review. So if you chose C, that is correct. That's because the presence of gas bubbles, air, in the necrotic bowel tissue suggests gas gangrene, typically caused by Clostridium perfringens. So let's do one more. I'll go ahead and give you a few minutes and then we'll come back and review the question. Okay, if you chose B, liquefactive necrosis, that is correct. Remember, brain infarcts undergo liquefactive necrosis due to enzymatic digestion of lysosomal enzymes, resulting in softening tissue. That concludes our video for today. Thank you very much for watching. Be sure to check out thehealingpowerofnature.com and also visit our Patreon for the best study materials on the market. Thank you again.